3, 4, 5 prizes to give away. We're not taking anything back to Australia, so keep submitting your photos. If you can't get them up on Instagram or you have a private account, feel free to email them to us, and we'll be stoked to put them up. Final presentation for this evening, we're going to be talking paediatrics. So let's have a nice big applause for Kim.
Hi everyone, thanks for having me here tonight. I've been told that paediatrics is always a commonly requested topic, so I hope I can give you something interesting to take home. The thing I love about paediatrics is that most kids are actually pretty well. Like, you can get them home. In fact, even big tertiary paediatric hospitals only have sort of a 10 to 15% admission rate, as opposed to most adult hospitals, which sit, 30, 40, 50, depending on the case complexity. But there are sick kids out there, and knowing who's sick and knowing when you've got to escalate is really important. So tonight we're going to run through about 4 different presentations, and we're going to have a think about the things you kind of don't need to worry about and you can send home with some reassurance, the things you need to be aware of, and then the things you can't miss. I got no conflicts to declare, and my nice turquoise colour is coming out blue on the screen, so that's sad, but anyway. I'm also very privileged to have my boss from 8 years ago heckling me in the front row, so if he heckles, feel free to heckle him, okay? Two, yes. My direct supervisor though. All right, so our first case, you've got, and you could be in the pre-hospital setting, you could be at triage as the triage nurse, or the first medical clinician seeing the patient, and you're confronted with a 5-year-old who's got a non-blanching rash to the face. And mum or dad have been reading all the articles on KidSpot and in the parenting magazines about non-blanching rashes, and they have come running to medical help. So have a little chat to your partner or your person sitting next to you about a couple of things that are on your differential list and what you wouldn't be worried about and what you would be really worried about. Maybe how the kid looks, maybe how they're behaving. All right. So this is not an exhaustive list, but these are some of the things that I think about. And the first one, which we will talk about in a moment, suction purpura, is one of my favourite diagnoses to make, up with pulled elbows, but we're going to talk about them later. So we've got here suction purpura, which you might not have heard of before, petechiae from straining, so from vomiting, coughing, heavy lifting, ITP, which we'll have a little chat about, and then the really bad things you don't want to miss are things like DIC associated with sepsis, inflicted injury, so petechiae around the eyes and from strangulation, or hematological malignancies like ALL. The thing with kids in this presentation is that history and if the child looks well is going to, or how the child looks is going to get you 98% of the way there. So this is my take-home point for you, is take a really good history about how quickly things have come on and also have a good look at the child. And that will get you your answer probably pretty quick and potentially without investigations. So this is one of my favourite things, and I vividly remember being a fairly junior registrar and seeing this kid with this purple rash in a circle around his lips, and it was a perfect circle. And I went and got my boss and I was like, oh, he looks really well, like he's tearing the waiting room apart, and I don't think there's anything wrong with him, but I don't know what to call this. And he's like, oh, I know what it is. And he walks out to the waiting room with me and says to the kid and the mum, have you been sucking a cup to your face? And the kid's like, yeah. and then my boss at the time was like, okay, off you go home. So this is a phenomena that you see when, the adult version would be the bruising you get from cupping in sort of Chinese medicine, but kids can actually generate enough suction power with a glass or a cup to their face that they end up just breaking all those superficial capillaries and getting this really well demarcated marking around their face, it's not a sign they have a problem with their platelets or their clotting. It's just the effect of suction on capillaries. Essentially, if the kid looks really well, there's a well demarcated line, just send them home. Yes, James?
And kids with early hirsutism?
Look, the image opportunities were limited, okay? I had to, steal a few photos from the internet, so sorry. He might be 13. Let's say he's 13. But essentially, if they're well, they're afebrile, they look fine, and they're tearing your waiting room apart, the best place for them to be is at home, okay? It'll get better over a few days. The other one you commonly see is post-tussive or post-vomiting petechiae, and these always happen above the level of the nipple, so that's in the distribution of the superior vena cava. You should get a good history of coughing, of vomiting, of some sort of heavy straining. And if the child, again, looks clinically well, is like trying to cause themselves a fractured femur off the play equipment in the waiting room, get them home, all right? No further investigation. But if you've got lesions anywhere else or the child doesn't look right, you need to go looking for the problem. This is something you see not uncommonly. So ITP is something you don't want to miss because these kids have really low platelet counts, but it's also something that varies in its severity. So ITP by definition is an isolated platelet count less than 100. They shouldn't have any other cell line abnormality, so their hemoglobin and their white cell count should be within normal range. The child should be well in themselves without any red flags on history examination, which we'll go through in a moment. And as I said, otherwise a completely normal full blood count except for that platelet count. The rash can look really impressive and it's always non-blanching. So you push on it, it won't go away. And these kids can it can often be a post-viral phenomena, or it can happen after live vaccines like the MMR. That's not very common, but it's sort of one thing it's associated with. Normally also the rash comes up pretty quick, so they go to bed at night the night before and then the next morning they've got this rash. So it's not something that you sort of see over days and days developing. The things you need to think about and look out for are severe bleeding complications. So you can get, for example, gastrointestinal bleeding. Teenage girls can get severe menorrhagia with this. They can get bad epistaxis. You can get bad bleeding from the gums. But they shouldn't have anything else going on. So they shouldn't have on history things like bone pain that's been waking them up at night or unexplainable fevers. They shouldn't have history of weight loss. And they should otherwise look pretty well. They shouldn't be pale and sickly looking. And most of these, so if they've just mildly affected, so they've got a rash and maybe like a little bit of bleeding from their gums or a little bit of bleeding from their nose, they can be managed at home with safety netting and paediatric follow-up and repeat bloods in a week. Okay, you don't need to admit them. But if they've got sort of some bleeding complications, they tend to get given prednisolone because this is an autoimmune process. Essentially, the body's formed antibodies against its own platelets. So they get prednisolone to deal with that. But the most important thing is that a consultant haematologist must look at that blood film before they get given the steroids. Because if we've got a missed haematological malignancy, you can induce what's called tumour lysis syndrome because steroids are part of treating haematological malignancies and they can get really unwell from that. And you've also started treating a cancer without the right protocol, and that's really bad. These kids have poor outcomes if you give steroids in undiagnosed malignancy. And then the severe ones who are bleeding way too much or have bleeding in severe areas like the brain, for example, get given intravenous immunoglobulin, which helps to neutralise those autoantibodies that I spoke about before. They also get high doses of steroid with methylprednisolone and just supportive care. The overall risk of intracranial hemorrhage is less than 1%, so it's really rare, but it's, I guess, what everyone worries about. My colleague sitting in the fourth row back there tells a story of a kid running around Tennant Creek with a platelet count of 1 and playing footy on the front lawn of the hospital, and having to sort of wrangle him back into hospital to try and prevent him having a massive intracranial hemorrhage. The other nice thing, I guess, just in terms of reassuring you and being able to reassure families, is that in 75% of kids, this is all resolved by 6 months. Okay, adults who get this can often have a much more prolonged or chronic course and have a lot more need for ongoing haematology follow-up. And then the things that you really don't want to miss are inflicted injuries. So it's awful that we still, have to think about non-accidental injury or inflicted injury. But strangulation can present with petechiae around the eyes, but they'll also often have marks around the neck. Hematological malignancies like acute lymphoblastic leukemia or acute myeloid leukemia or APML, and then sepsis with DIC, which is the one that's in the media all the time, and classically being meningococcal septicemia. These kids don't look well, okay? They look really sick. If you're covered in a non-blanching rash and you look well, it's not going to be meningococcal. Like, it's progressed far enough that where you're going to be looking sick. But most states and most hospitals have sort of a protocol for working up the kid who's got a fever and has some non-blanching rash, and you should absolutely follow that to the letter of the law, mostly to protect yourselves. So the take-homes here are take a good history and be aware the unwell-looking child. So unwell-looking kids with non-blanching rashes, take them really seriously. And also, I know a lot of the paramedics, at least in Victoria, I have a protocol where they can call through and we can authorise antibiotics for these kids with the ambulance service. And so if you're worried that the kid looks unwell and has a non-blanching rash and you've got the ability to do that, please call it through and we will authorise some ceftriaxone. All right, our next one, really common every day in the paediatric emergency department, ingested foreign bodies. So anyone just yell out, what are the ones you worry about? Button batteries, good. Magnets. One magnet, James, or two? Two. Okay, and any other weird and wonderfuls you've heard about? Needles, yeah. Needles can be a problem, depending on where they get lodged or don't get lodged. Anything else? Medications, yeah. We're not going to go through the list of 1 or 2 pill kills today, but they're worth thinking about. Dishwashing tablets or caustic ingestions, good. Water beads, good. All right. So on the whole, most things that kids ingest that are foreign objects are going to be fine. And you spend a lot of time just reassuring parents that the gastrointestinal tract is a very robust organ that will bind things up in the food and will, expel it at the other end. The bad things are large objects, so generally greater than sort of 2.5 centimetres in diameter or 6 centimetres long if they're a long, thin object. Super absorbent polymers are water beads, which we heard someone yell out before. And then the really bad things are button batteries lodged in the esophagus. So button batteries that make it to the stomach aren't too much of a problem, but if they get stuck in the esophagus, that's where they're bad. And then magnets, and I've put magnet plus because it's magnet plus another magnet or magnet plus a metal object that the magnet can attach to are a problem. So we'll go through each of those. The things you really want to clarify is the timing of ingestion, what they think the kids had, known GI tract abnormalities. So, for example, the 2-year-old who's had a tracheoesophageal fistula repaired when they were a neonate, that's important to know because they might have strictures or they may not have normal GI transit. And if they've got any symptoms. So if the kids have no symptoms, that's really reassuring. But if they're drooling, that would suggest that that button battery is stuck in the esophagus. If there's regurgitation or early vomiting after intake, that would suggest it's sitting at the pylorus or in the proximal duodenum. If the kid's got any pain, you're starting to wonder about an obstruction or some sort of perforation. And if there's a history of coughing at any point, or choking, then you really need to consider, is this actually an inhaled foreign body as opposed to an ingested foreign body, which has a completely different set of management and investigation. So low-risk things are most of the things, as I said before. Even sharp objects can be low risk. So things like little sewing pins will pass through. Okay, so if the kid has managed to swallow it, you get an x-ray, you see it's in the stomach, and the kid is completely fine, then you can safely discharge that child with appropriate safety netting if you assess the family to be able to access healthcare relatively easy. You know, if they live 300 kilometres from their nearest healthcare service, then maybe you'd keep them and watch them for a while. But if they're 10 minutes down the road, I'm very happy to send them home. Coins are really common to ingest, and generally up to the 20-cent piece size, you're okay. 20 cents starts getting stuck at the pylorus in younger kids. 50 cents tends not to make it down. So, and then I've one really common one we see a lot of that often gets sent in by the various telehealth services around that sort of run on protocolized decision trees is the family will give a history that, oh, my kid has dropped a cup and we think they've swallowed a bit of the broken cup, or the kid was holding a cup in their mouth and banged themselves on the table, or, you know, some far-fetched story. And maybe the kid's got like a little tiny cut on their lip, and somehow this is translated to the kid has swallowed a piece of glass or china. Just reassure them and send them home. It'll be fine. If the kid has no symptoms, they can go home. Water beads are really interesting, and I knew they were bad, but I didn't know a lot about them until I did a little bit of research for this talk. So I think they first came to popularity making pretty flower arrangements for, you know, various hotels and people's gardens and things like that. And they have been used in horticulture as well as a water storage and delivery device. They start out as those tiny little, like 1 to 2 millimeter beads, and then once water's added, they can get up to sort of 60 millimeters in diameter, which you can imagine in a small child, if they ingested 1 or 2 of those little 1 to 2 millimeter objects and those swell exponentially over time, it's going to get stuck somewhere. This paper that I've put down the bottom was a review of essentially 43 cases that were published in the literature. And of those 43, every single child was vomiting. Not a single child was not vomiting as their presenting complaint. They all had obstructions in the duodenum or small bowel, so they essentially got to the size where they're going to obstruct quite early and in transit. 2 of the children died because it wasn't recognised and they ended up with perforation. And in terms of imaging, so basically every kid got an ultrasound, and of those 43 kids, 34 of the 43 got ultrasound, and in 5 of them they didn't find anything. So it was non-diagnostic in 5. In 28 of them, 6 it was non-diagnostic, and 28 they saw something was wrong. I would have thought you could probably see that well demarcated round thing on ultrasound, but I'm not an expert small bowel sonographer. And then 10 kids actually got CT imaging, and even on CT, 5 of them, they didn't make a diagnosis. So I think the take home sort of from this is involve your surgeons early, and if you're at a non-paediatric surgical site, probably do the best imaging you can and then get them to a surgeon, because they need a diagnostic laparoscopy / laparotomy. And children under 4 probably are the highest risk. James?
In this, sorry, that's a question. Yeah, it's a serious question. So in this paper, were most of these kids treated operatively?
Yes.
Right, so if this is in the small bowel,
you've got to get it out. Yeah.
Right.
Are there any similarities between these and like silica gel, like sachets that come in like every shoebox?
Yeah, silica gel's not a problem. Yeah. I once did a research job sitting next to the...
Whatsoever.
I know, but I'd like it from her.
I once did a research job sitting next to the Victorian Poisons Info Centre, and so I could hear all of their calls coming through, and they get called about the silica gel like all the time. Alicia, you did that job too, all the time.
Like
Multiple times a day, yeah. And their reassurance is, how about you just give them a little cup of milk and they'll be fine? And that's essentially what they say. And then button batteries. So button batteries in the esophagus are really bad. They start burning through the esophagus in 15 minutes. And the longer it takes to get this kid to definitive care, the worse their outcome. And the issue is that that burn can start extending posteriorly towards the vertebral column, and then sort of you can get infection through the whole mediastinum, or it burns through anteriorly into the trachea and the airway. And that's really bad, and you get fistulas between two things that shouldn't be joined. And the complications include things like mediastinitis, which has an incredibly poor prognosis regardless of who gets it. This is a kid I had at one of my jobs about 6 years ago. I was a very baby junior consultant, and this child was brought in by the ambulance service drooling, and the call through was an airway foreign body or an airway button battery. And we said, we cannot deal with this child at this hospital. Please take them to Tertiary Children's Hospital. And they said, no, we can't. And I said, take them. And they still came. And so it delayed the transfer of this child by about an hour and a half to where they needed to be, which is the operating theatre at the Tertiary Children's Hospital. And he had a significant esophageal burn by that point. So that's not a criticism. I can understand the stress of having a kid who looks like they've got, respiratory distress, but they're actually just gagging and can't swallow their secretions. But you've got to get them to where the procedure can be done. And these kids, when they swallow a button battery, it just gets stuck. It gets stuck in the esophagus, and they need to have it pulled out ASAP. In terms of what you can do in the meantime that's actually practical and might have some benefit is give them honey. So if you're a paramedic picking this kid up at a house, ask the parents to find the honey in the house and take it with you, and take a spoon and give them a spoonful of honey every 5 minutes. And there's some evidence that this can reduce it sort of coats the outside of the battery and gives you a bit more buffer zone, basically. And that's all you can really do. If a button battery's made it to the stomach, it is likely to pass through with no problems. Those kids can be sent home with safety netting advice. It's the only one where I actually tell the parents they should check the poo for the foreign body. I don't tend to get parents to look through poo for foreign bodies, but button batteries, it's good to know it's out. And if they haven't seen it in 3 days, I tell them to come back and we'll just re-x-ray and make sure it's gone. Obviously, to return sooner if they get any symptoms. So pain, they look really unwell, they're getting black or tarry stools, any of the things that would suggest you've got badness going on in the belly. The other one, as was mentioned before, is magnet plus something. So this is a little ring of magnets that are all stuck together, and this is where it's really important to know when they swallowed it. So did they just swallow a whole bunch of magnets in one go, or did they swallow a magnet and then 4 hours later swallow another magnet? And that's important because the issue is that once a magnet gets through to a loop of small bowel, it can then attach to something else that's sitting behind, downstream or upstream to it. And then those two pieces of bowel can stick together and you get necrosis between the bowel. And then you get a perforation, and then you get septic and die. And that's not good. We don't want children dying. The other important thing is with magnets is to get a lateral x-ray as well. So in kids for foreign bodies, we normally just do a babyogram, or we x-ray them essentially from nose to pelvis, and we just do an AP film. But with a magnet, they're so radio opaque that you may not actually see if there's a second object. So getting the lateral, so you get that different perspective, can get you out of trouble and help you know where you stand. So So take homes here are have a high degree of suspicion for badness with ingested foreign bodies. So any symptoms take really seriously. And honey for button batteries, and please get them to definitive care as soon as you can. Will.
Another question from the front row. If you're in a situation where you cannot get expert paediatric ENT to remove that, have you seen any ways of getting that thing out in an emergency department?
Not in an emergency department. I mean, I don't know. I can creatively think of multiple ways that I might try if I was in a really bad situation and a plane couldn't come quickly. Whether they should be discussed in an open forum like this is where you and I can discuss later. But in my head, I'm pondering things like IDCs and, ketamine. All right. Another one that's really common, especially in Melbourne, where there is so much pollen, and it's just, honestly, I love Melbourne. I still don't know why I moved there, because like everyone who moves to Melbourne in their 30s ended up with horrendous hay fever, despite never having it in their lives before. But periorbital swelling and redness is not an uncommon presentation. Any thoughts on what might causes, other than allergy? Heard cellulitis, orbital cellulitis. There's not a lot to talk about here, but it's more about the examination. So the good things are the allergic reactions. You can sort of manage these pretty simply. The things you don't want to miss is periorbital cellulitis, and then the really bad thing is orbital cellulitis. Some people call this post-septal cellulitis. You might hear it referred to as that. The thing here is that you've got to examine the kid, okay? And kids can be really hard to examine, and examining eyes in small children is really hard. And especially if they're in pain, especially if they're sore. They won't just sit there and let you pry open their eyes and have a proper look. And occasionally you need to sedate kids to get a good examination for this, and that's okay. So allergic reactions, and this includes things like mosquito bites causing big localized reactions, acute onset, often bilateral if it's a environmental allergen. They're itchy, they're scratching, they're afebrile, and they shouldn't have any changes to their actual eye examination. So sure, you can't get a sort of a vision assessment on an 18-month-old, but you can see if they can fix and follow an object that you wave in front of their face. Older kids, you can do a proper visual acuity on. These can be managed really simply. Give them proper dose antihistamines, so that's more than what it says on the bottle. Cold compresses, and sort of set the expectations that they're still going to be swollen tomorrow morning. That's okay, it will get better, and give them return precautions. One thing you often see kids come back with is, it's worse this morning, and that's because no one's explained to them that when their kid who's got acute histamine-induced swelling sleeps face down in their bed, it's just going to get worse, and the next morning they're going to look horrendous. But if they got up and walked around for an hour, they'll probably look a bit better, and they don't need to come back to the emergency department. Periorbital cellulitis is essentially infection of the skin and soft tissues at the front of the eye. And so there's this sort of, it's not an imaginary barrier, but it's a barrier called the orbital septum, which is a very thin layer of tissue that divides the front of the eye and the back of the eye. So periorbital cellulitis is at the front, and essentially they kind of divide this into mild, moderate, and severe. So the severe ones are all young kids, so all kids under 3 months just get treated as severe. Kids who aren't vaccinated properly, so Haemophilus influenza B, which is a disease that thankfully most of us have never heard of because vaccination is very good these days, can cause this. And all of those kids get IV antibiotics, and depending on your setting, you may actually give them MRSA coverage as well. If you've got a kid that you can get a reasonably good look at their eye, they've got a bit of a fever but they otherwise seem okay, they still get admitted for IV antibiotics because everyone's worried about this sort of tracking backwards. And then the mild kids can be sent home with high-dose Keflex and just managed as an outpatient, which is always nice. And then what we worry about is orbital cellulitis. So this is where you've actually got involvement of the eye or the structures around the eye. So the muscles that help move the eye, it normally extends from sinus. So these kids almost all have sinus disease, so about 80%. And the complications are what makes people worried about this. So you can get vision loss, you can get cavernous sinus thromboses in the brain, and you can get infections that track back. So meningitis, abscesses, subdural empyemas. It's not a good combo. The thing about these kids is they're really uncomfortable. They might look a bit sick or be very sick systemically, but they're really miserable and they're holding their heads still because they don't want their eyes to move. So sometimes they get triaged as neck stiffness, but it's not their neck that's stiff. They just don't want their eyes to move, so they're holding their head still because your eyes naturally move as you move your head. They all need to be... They need CT imaging, so it's one of those cases in paediatrics where you just bite the bullet and order the CT and get ENT and ophthalmology as your sort of primary consulting teams, but a lot of hospitals, they get admitted under general paediatrics anyway. IV antibiotics, again with vancomycin coverage if you're in a high MRSA area. So big things are abnormal eye movements or inability to move the eye, and changes in vision are very worrying, and get the right people and the right imaging early. And if you're concerned about the diagnosis of orbital cellulitis and you're waiting on the CT, just give the antibiotics. The dose is not, they've at least got periorbital cellulitis, so they're going to get IV antibiotics anyway, and if you give them early, that's not a bad thing. James.
I mean, periorbital cellulitis doesn't go back.
It shouldn't, but I think it's people worry about missing early orbital cellulitis.
Ah,
Yeah, paediatricians. Yeah.
check.
Maybe like you haven't got the signs. And now my favourite. I actually prefer 2-year-olds not using their arm over 4-year-olds, but anyway. So, any thoughts on elbow pain or kids not using their arms?
Pull elbow.
Yeah. It truly is the reason I do emergency medicine. It's actually the thing that keeps me in the job. Is mostly fighting my colleagues sitting back there for the pulled elbows at triage. Like to the point that I will come running from the short stay unit when I see a 2-year-old not using arm as the triage, and then fight it out with my colleague who's working in adult resus. Yeah. So, who has seen or managed a pulled elbow in this room? So at least 50% of people. Okay, good. We'll talk through them in a second.
Who's reduced a fracture thinking it was a pulled elbow?
Me. Yeah. I kind of couldn't come up with anything other than various broken things to talk about the bad bits, because there's lots of things you can break around the elbow. Osteomyelitis is something you need to keep in the back of your head. It is rare to get it in around the elbow, but I saw 2 cases of radial head osteomyelitis last year, and all presented as a kid like looking a bit pulled elbow-ish, holding their arm and not really doing a lot with it, or both of them systemically well, so they had slightly delayed diagnosis, but that's okay. And then the bad things are the messy dislocations, the messy fractures with neurovascular compromise, and then some of the epicondyle and condylar fractures. So things to think about and look at, a lot of ortho stuff talks about look, feel, move as one of your assessment things. I was trying to get what's the word I'm looking for? An acronym or something. I went with the P's. So I think with little kids, actually seeing how they're holding their arm is really helpful, because pulled elbows are always by their side. They're just like sort of limp and not doing anything. Sometimes clavicles are also like that, but any kid with a broken elbow is normally like supporting it because any movement hurts a lot, and so they're trying to guard it. Checking for their pulse and their perfusion and seeing how they can move their fingers is really helpful just in terms of their neurovascular status. So that is how a kid with a pulled elbow stands. They're fine if you don't go near them. You go near them, they scream. And they're really easy to reduce. So, and once you've done a few and you understand what you're doing, it is honestly the most satisfying thing you will do all day. So the actual pathophysiology behind it is that little kids don't have a nice big radial head that holds their annular ligament on. And kids can, when their mum and dad is like trying to save them from running in front of a car and like grabs their arm and the kid's pulling in one direction, that little annular ligament subluxes. The other classics are they're just walking along holding their hand and the toddler just has a tantrum and throws themselves to the ground while holding hands. And the parents come in really distressed because they think they've done it. I'm like, no, the kid did it to themselves. And then you often hear these like stories of like, oh, I don't really know what's happened. They've just stopped using their arm, but we were rough and tumble playing on the park or on the grass or on the couch or whatever. And 9 times out of 10, those are pulled elbows too and not a fracture. So it is worth a gentle attempt at relocation if they look like that. So thumb on the radial head, and then they're always already in a bit of pronation, so you just hyperpronate, and you'll often feel a little click, and they will scream at you, and you leave them alone for 5 minutes, and then you go back and you give them a high five and you discharge them home. And if they can high five, it's in, they can go. There's a nice little information sheet on the Royal Children's website to give the parents for reading. If that doesn't work, then you do it the other way. So you thumb on the radial head, supinate them, and then flex them in one sort of fell swoop. And if that still doesn't work, then you need to reconsider your diagnosis. So if you go back and reassess them 5 minutes later and they're still not moving it despite your best attempts with Bluey on your iPhone and, you know, bribery with bubbles and stickers and whatever you've got, then get an X-ray. And if the X-ray is normal, send them home for 24 hours and bring them back to reassess them and have another think. And don't over-image them. The osteomyelitis is interesting because often these kids, again, they're young and they can't give a good history and they can't localise their pain very well. And they just come in not moving a bit of their body right or just not playing as normal. And parents are really good at picking that their kid's not doing what they normally do, so take that seriously. It's not to say that you need to dive in and do bloods and advanced imaging on every kid who's not moving something right that day, but if they've got a fever and they're not moving a joint correctly, then you do. Or if they look unwell, you do. But in the well child who's got good healthcare access and you're happy that they can access healthcare again, then it's not unreasonable to re-review them in 24 hours with some Panadol and some Nurofen over that time. And because if it's a small soft tissue injury, it's probably going to be improving. You know, kids can get sprains just like all of us can, and they can't really tell us. So, but if they haven't improved at that point, then getting some blood tests, checking their inflammatory markers, some blood cultures, and then normally admitting them for an MRI of that area is what you end up doing. Oh. Are you okay? It's okay, we'll hold tight. Someone had a seizure or? Seizure? Okay. Hopefully it's not someone who had a head injury today. Yeah, let's just pause while we...
We'll just take 5 minutes, guys.
Yeah.
And we'll resume it shortly.
You're doing great, Kim.
It's a first. Make someone have a seat. Why you went in front of the
Sorry, and my colleagues.
I do have a question. Is there something about is it that makes them start? Like, do they start?
Because you can swallow double age. It's just positive negative and stuff.
But does it start? Or is it just the size?
thought I'd have a laugh. Paul made an indulgent as a physician that dabbles in feeds.
Yes, me too. I dabble.
No sense. My opinion. Second one is a fracture.
Yeah.
There's an upgrade. The smaller we need to run away from it. Successfully
Made up for it.
I'm so proud of you. As my little cousin.
Yeah, we got to. Jack, was it for 6? I don't know. Are you going to come up? 8 long ones. Where are you going to be for dinner?
Everyone here. Everyone's.
Yeah, everyone's sent out ready to.
And so that's why, like, pediatric coronary but most of the registries we have
Yeah, I mean, so I'm fully adopted.
I sometimes order
One of my best mates called me a few weeks back and said, "It's your tablet." So I called my mum. I'll maybe they push up and construct. What do I do? Asymptomatic Just a classic pseudo-vision.
Okay, guys, thank you very much for your patience there. We are now ready to resume. So, thank you, Kim.
So as we were saying, kids who have good access to healthcare, it's okay and safe to reassess them in 24 hours. And they generally need advanced imaging with MRI. The other option you can use is bone scans, but non-tertiary paediatric places don't necessarily love doing diagnostic bone scans on kids because they can be a little bit hard to interpret, is my understanding, and they can just be hard to access as well. So MRI under sedation is normally an easier option. And if there is osteomyelitis in most kids, it's Staph aureus. Increasingly, I'm seeing a lot of the small areas of osteomyelitis just managed with really high-dose oral antibiotics in the community, which is good for kids and families. And increasingly, some health services have access to HITS services for kids, so they can have a PICC line put in, and if they need IV antibiotics, that can all be done at home, which is nice. Yeah, thanks. So that fracture fragment's essentially compressing the brachial artery, and you want to relieve that as soon as possible. So if you've got a dusky arm that doesn't look very good and an elbow that looks like that, the best thing you can do is give the kid some good analgesia. So in the field, that might be something like intranasal fentanyl and some penthrane, or in hospital, we might use intranasal fentanyl and nitrous or ketamine. And all you're wanting to do is put your fingers on the radial pulse, where the radial pulse should be, and just gently extend that elbow out until you get that radial pulse back. And once you've got the radial pulse back, splint it in that position and get them where they need to go, okay? Ideally somewhere that can put pins in that and take them to theatre. So take homes, pulled elbows are the best thing in emergency medicine. It's a dead set good reason to keep doing emergency care. And elbow fractures can be really high risk for complications. If in doubt, get expert help. And also, if you've got an elbow injury you're not sure about, there is nothing wrong with putting them in a back slab for a week and re-x-raying or getting someone else to have another look in a week's time. That is a very legitimate treatment plan, which I do regularly. Any questions? James has left, so there's no more from him. All right, thanks very much, everyone, for your time.
Thank you so much, Kim. That was brilliant. And also thanks to Brennan for our first presentation this evening. Tomorrow is going to be a brilliant day. There's more snow on that mountain that we don't know what to do with. It's going to be cold, so make sure you have your gear all dry, ready to go for the morning. First lifts are my pick because everywhere's going to be great. We've got 2 awesome presentations, and we've got our closing party to finish it all off. So don't want to sound like your parent now, but go home, get some good sleep, and get ready for tomorrow. Enjoy, guys.
Thanks very much.
That's amazing, Jim. Yeah, so it's exactly what we're after. So, yeah.
It's an interesting audience to try and pitch it to. Yeah.
That's exactly, because I think often where it gets lost is that people don't get that like take point. So people are like, oh, that's really good, that's interesting, but then they walk out the door and sort of forgotten. But I think what I love about that is that you had those like,
Thanks, yeah. I hope it was alright.
Yeah, no, it's excellent. We'd love to have you back, so let me know.
Well,
when
I think everyone's planning to come back, so.
Oh, brilliant. I'll be in touch for sure.
Alright, cool. Thanks heaps.
Not at all.